My name's Tess. I am a nurse of 10 years in endoscopy. I took on the care navigation role alongside Karen last year when Trudy created the role, and we're just going to tell you a little bit more about what we do. When patients come in for an endoscopy, there are lots of reasons why they might feel worried, scared, not attend for their appointment. We first identified some of the barriers that patients face when they come into endoscopy. People are particularly anxious. We work with patients with a learning disability and autism, history of trauma. There are an enormous number of barriers to accessing our services. First, Karen and I identified some of those barriers and then looked at how we could break those barriers down.
So breaking down the barriers to care, so we're obviously committed to making endoscopy more accessible and supportive by emotional and practical support, tailored care. We work closely with the learning disability, autism, mental health teams in the Trust to provide personalised support and offer reasonable adjustments to our patients. Accessible information, trauma-enforced approach. We support an awful lot of patients that have had a lot of past traumatic experiences, so they feel safe and cared for when they're within our care. We have a holistic coordination. We offer transport assistance for those patients that need it. Patients with dementia and Alzheimer's, we obviously collaborate with their carers and relatives to minimise distress and ensure that their consent is in place. We work closely with our community partnerships, and we create a safe and welcoming environment that builds trust and confidence for our patients.
So, what have we managed to achieve in the about a year that we've been in post? A year seems like a long time, but it's not really that long. We have created and improved the pathway for oncology patients who require flexible sigmoidoscopies. Karen started in October 2024, just before I started, a propofol call-ahead service. Some of our patients that come into the BRI require their procedures to be done under propofol. They are very sought after, well utilised and expensive lists to run. We wanted to know what we could do to avoid DNAs and get a better list utilisation, so Karen brought in the call-ahead service, which has been very, very successful. We are working on an InTrust project which aims to grow the confidence, capability and capacity of our clinical services. That will be looking to design and deliver services together with our patients' communities. We're looking at focus groups and getting people in to working with our patients and service users to see what we can do to better our services further. We've worked alongside the paediatric gastroenterology team. That was about streamlining and improving transition processes for children moving from child to adult services. I think that's really important. Going from paediatric services where there's a huge amount of support in and around an individual to adult services can be really quite frightening. So we were looking at what we can do to ease that transition. We have looked at our DNAs for endoscopy overall and implemented a pre-appointment call, a call-ahead service for patients who repeatedly DNA, not just for endoscopy but for other services as well, but particularly focusing on endoscopy and thinking actually what is it can we do to better utilise our lists. And we've spent nearly a year really trying to teach others and promote our role and make sure that people know that we're out there to help. So we're going to be hopefully advertising to local GP surgeries. We get lots of straight-to-test patients now for colonoscopies and gastroscopies and saying we are out here if you've got patients who are anxious, who have undergone some sort, had some sort of trauma or anything that might prevent them from coming in and using our service. We're here. Please utilise us.
So what has been the impact of this new role? As Tess has said, it's only been a year, and if any of you work in the NHS, you know that that is not very long to turn the tanker in the NHS, but we have already seen a really positive impact. So firstly, of course, it's about the patient experience. It's a more personalised, proactive experience. Patients can, before they come in, before they even have to reach the doors of the hospital, they know that somebody will be there for them. Karen will go down, and it costs nothing, but she'll meet them at the front entrance, just so that they've got that face and they've got that connection, and they're brought to the unit that way. It's an inclusive approach. Every single patient is asked when they're booked in, do you have any additional needs? Would you like to speak to the navigator? And so people can put themselves forward. It's not around a healthcare professional choosing for them. We've had, the feedback has been lovely. I think sometimes in the endoscopy world, it's about numbers. Everything becomes focused on numbers. How many people can you get onto a list? We call them points on a list. It can become a little dehumanizing, so I think it's so important to bring it back to patients and to hear what they say. People will say to Karen, I wouldn't have come in without you, or I've never been able to come in for an endoscopy. And these are patients who we may or may not be able to exclude cancer on and will have been sat at home. It's changing the culture of the unit across all of the trust. And speed up, I'm so sorry. It's improved efficiency, cost effective, and most of all, it's reducing health inequalities.
Sorry, we need to whiz through. There's a few case studies, but we'll skim over those. And we've got some amazing patient and staff feedback as well for the role. So number of patients we've supported so far, I think these have gone up a little bit now, but we've supported between us 866 patients, which is amazing in a year. So the future, we are obviously going to identify factors delaying patients' inpatient endoscopy procedures, enhancing communication to better meet the diverse needs of our patients, continue to audit and evaluate and streamline a stable cirrhosis pathway for our patients as well.
I think we'll wrap it up there because there's a man holding up a time sign.
Thank you, ladies. It's the worst part of my job asking people to wrap up a little bit, but we do want to be completely fair to all our presenters. So it is a really difficult one and a really interesting project to hear from. So thank you very much for wrapping it up. I have to say, just to give you that look, there was a key learning slide here. You can all have a quick look at that. And then there was a thank you slide at the end. So thank you very much indeed. Now, don't disappear because there might be a couple of questions. Gentleman here. I get into awful trouble if I'm not scrupulously fair.
Thank you. This is such an amazing project targeting at reducing inequalities, and I just wonder how scalable you think it is to other services, the model that you've adopted.
Thank you for the question. I think that's something that is very feasible, and I think you need to look at what works for your service. For endoscopy, which there is quite a lot of medical complications, we have qualified nurses. But this could be a band 4, band 3, and you could look at what works for your service. And because it may not be an initial health economy, but it will be a health efficiency, because we all know about people that don't come to clinics. And it's also about exactly like the fabulous lady that was talking in the music hall place was saying around, it's about the people we don't know about. And I think that they are a hidden cost out there and we don't know about them. So if we can bring them in and get them seen in a timely fashion, that again will be a health efficiency. And I think in this age now where everything is boiling down to the nuts and bolts of money, if you can demonstrate that health efficiency, I think you are more likely to. And I think it's about looking at your team and seeing if there's people that can take on that role. It may not need to be full-time, but if you can take on elements of the role.